Each year, Microsoft Research hosts hundreds of influential speakers from around the world, including leading scientists, renowned experts in technology, book authors, and leading academics, and makes videos of these lectures freely available.
I'm very pleased to announce that we're having Hunter Hoffman from the UW. He's a professor there and a researcher in cognitive psychology, and he's done some really great work with using games to help people mitigate pain and address that. So thank you for those watching remotely, and for those that have attended in person, Hunter Hoffman from the UW.
Thank you. Thank you very much. So I'll be giving a presentation about using virtual reality for pain distraction and using it for post-traumatic stress disorder exposure therapy. I'll start off showing a short video clip, a 1-minute video that sort of gives you an overview of the research on pain control.
We were cooking pasta and Nathan touched the pot and pulled it on himself.
6-year-old Nathan Neisinger has endured skin grafts, months of wound care, and more pain than safe doses of narcotics can kill.
It can ease their pain, but their mind's still directed to, they're going to go into the tank room, they're going to get scrubbed down.
Then there's physical therapy to stretch his scarred skin. But through it all, Nathan's brain can go off to play in a 3D computer-generated world called Snow World.
What we're really trying to do is just to pull his attention away from what's happening in the therapy, to put his attention in the virtual world, and by virtue of that have him experience less pain.
The University of Washington psychologists Hunter Hoffman and David Patterson created Snow World for treating burn victims. Their clinical studies with patients like Nathan are showing how effective virtual reality is at fighting the fire of burn pain.
Patients who went into virtual reality reported having large reductions in how much pain they were experiencing, typically 40 to 50% reduction on average.
In an article in Scientific American, Hoffman described how a special virtual reality helmet that would work in an MRI scanner confirmed this. The brain scan showed far fewer pain signals with virtual reality than without it.
So I didn't feel anything really, but I did feel some pain, but not that much.
Anything to get his mind off, seeing the nurses with their, equipment trying to work on him helped out a lot.
The researchers hope virtual reality will soon be available to help many more patients escape their pain. I'm Oren Schoenfeld.
Okay. So this research is an interdisciplinary research project. It's a collaboration between the Human Interface Technology Lab, which is a very large virtual reality research center at the University of Washington, and then we work with Dave Patterson at Rehab Medicine, Harborview Burn Center. I'm also collaborating with Sam Shar in anesthesiology, doing some controlled studies. You'll hear about all these shortly. And I'm in mechanical engineering, so we're creating various new helmets that I'll be able to show you today. And then we're also starting to expand to other research centers and hospitals, making Snow World available. As you'll see, I was in kind of financial trouble, and Paul Allen bailed us out and got kick-started this whole project. So these are Dave Patterson, Gretchen Carower, and Sam Shar, and Donna Nakamura is a therapist who's been real helpful. So most of the time when patients are just lying around in their beds, opioids work well for controlling their pain. But during physical therapy and wound care, opioids are often not strong enough to control the pain. So here's some data to back that up. Here's some patients while they're lying in their hospital beds. Excessive pain is shown in red, and you can see there's very little red. So these same patients during wound care, the vast majority of them report having severe to excruciating pain. Pain has a strong psychological component to it, so the same incoming pain signal can be interpreted as more painful or less painful depending on a number of psychological factors, such as where the patient's focusing their attention, whether they're anticipating it to be excessively painful, whether they feel like the pain is harmful or helpful. Sometimes that can influence it, whether they're anxious. So all these psychological factors can amplify or minify how much pain the patient feels. In this case, what we do is pain requires conscious attention. So that's kind of the idea behind putting somebody to sleep. If they're asleep, they don't feel pain, they're not conscious. So what we're doing here is kind of a trick where the patient remains awake, but we lure their attention into the computer-generated world. So you can think of attention as being like a spotlight where you can direct your cognitive resources towards some information at the expense of other information. So whatever you shine the spotlight on, your brain can't process all the information from the world at the same time. And usually where you look is where your attention is. You can fake people out by pretending to look at one person and listening to another conversation, but usually where you're looking. So in this case, instead of looking at your wound, which is what patients typically do, looking at this nasty open burn that's being worked on with all the instruments that are kind of scary, scalpels and tweezers and so instead of looking at all that scary stuff, they go inside this computer-generated world, snow world. They have the illusion of being in this other place. So the place where you are is where most of your attention is, and that's the idea, was to lure their attention away. In this case, we created Snow World. This is the first virtual world ever designed for pain control, and this one was specifically designed for treating burn patients. So a lot of burn patients report re-experiencing their original injury during wound care. So in other words, the wound care kind of reminds them of actually being burned. So the icy motif, the snowflakes, cold igloos, that's all designed to be kind of the antithesis or opposite of fire. And we deliberately use colors that don't remind people of fire. All the explosions are white puffs or purple puffs. No, fiery looking stuff. So when you fly through here, this is just a snapshot. You can actually go through into the canyon. This will be available in the cafe this afternoon if you want to try it yourself. And you can shoot the river and it makes a splash. That took 2 years, so I hope you'll do that. Here's the new version, Imprint Interactive Technologies here in Seattle, which is a spin-off company from the HIT Lab at the University of Washington. We've been collaborating together since '93, and I was invited by the Smithsonian to give an immersive demo, which is currently on exhibit at the Triennium in Manhattan. And so we had to kind of, plus for the patients, we were ready for a new version of Snow World that was more attention grabbing. So Imprint was really excellent at upgrading this to a whole new level. Some of the studies that we've done, one of the first questions people asked was, can't you just use a video game to do the same thing? So one of the very first studies we did, we compared VR to Nintendo video game. And in this case, we did a within wound care design. So the patient had a burn wound on his leg from gasoline, and he had a transplant of skin, and it was successful. So now they're ready to take the staples out that were holding the skin on, because it's already growing onto the leg. So he had 11 staples out. He had 5 staples out while he was playing Nintendo, and then we took his pain ratings, and that will be shown in the following graph in red in a second. Okay, and then the same patient went during the same wound care session with all the same drug levels, etc. Went into virtual reality during the last 6 staples. And then we asked his pain ratings for that. That'll be shown in blue. And the results couldn't have been more dramatic. In fact, we almost had to, you almost couldn't see the bars at the bottom for virtual reality. So the kid was just in severe pain during Nintendo. In fact, in all honesty, as he was playing, he was glancing down and watching because he didn't have a helmet on. I think that's one of the advantages of virtual reality, is it blocks your view of the wound care. But his pain during Nintendo was high, as shown in red, and then his pain during VR was dramatically reduced. His illusion of going inside the virtual world was really high in virtual reality and was low in Nintendo. So these video games are great. They're very attention-grabbing, as any parent or kid will tell you. But when it comes to the illusion of going inside the virtual world, as I think you'll see when you try the demo of Snow World, that's what we're all about with Snow World, is trying to create this illusion of going inside the virtual world. We have all kinds of techniques that aren't used in video games that help create this illusion, and we think that's what makes VR so effective for pain reduction. In a lot of ways, it's inferior to video games, I'll tell you that right now, and there's a lot of room for improvement. So here's the second patient. That first one you probably thought, oh, that's just a small burn, I'm not impressed. Well, here's a kid with a much worse burn. He was out drinking with some buddies out in the woods. They created a bonfire. He saw that the fire was getting bigger and bigger and was getting closer to the gas can that they'd used to start the fire. So he was carrying the gas can away from the fire, tripped in on a log in the dark, got gasoline all over himself, and was really unfortunate that a plume of the vapor just temporarily connected him to the fire. So now he's all on fire out in the middle of the wilderness. So he had a really bad burn. He was, everything in red is a burn, and then unfortunately they harvested skin from the parts that weren't burned, so it was even worse than it looks. He was having a lot of trouble with his pain. But even he showed large reductions in pain. We did the same study with him as before, Nintendo versus virtual reality. Big drops in pain. Those are dramatic reductions in pain. Typically, opioids drops pain by about a third. So, these are huge drops. And the illusion of presence wasn't as high with this guy, consistent with the idea that there may be a relationship between how much the person goes into the virtual world and how much pain reduction they get. So already, even with our first two patients that were published in the medical journal Pain, we're already starting to see this interesting relationship between attention, between presence and pain reduction, and implicating an attentional mechanism. So sometimes things work for reasons, and you think you know why, and it may not. You may be wrong. So we're encouraged to see that it look like we understand at least somewhat what's going on. Here's what we were using before we got funding from Paul Allen. We were using Spider World, which was designed for treating phobics, not burn patients. And some of the patients were like, "Get that thing away from me." So they reach out and they could touch this furry toy spider and have the illusion of physically touching the virtual spider. So this was pretty attention grabbing, at least for a few minutes. But for long-term treatment, it wasn't ideal, but it did work. Here's a patient getting stretched. So in addition to having their wounds cleaned daily to prevent infection, they have to take off the dead tissue, otherwise then in the afternoon they have to stretch their newly healing skin to maintain the range of motion, because skin has a natural tendency to contract. And if they do the range of motion, it reduces the number of surgeries they need, because they don't have to have as many skin grafts. Here's a cute little kid getting range of motion in Snow World. And we did a controlled study showing that big reductions in pain, VR versus no VR, during physical therapy. And we have some interesting preliminary data that needs to be followed up on, where we showed there doesn't appear to be any reduction in analgesic effectiveness with multiple treatments. So here's where what you see is the number of days they came back for therapy. So those earlier studies, a lot of times we just did one short little study on one day. So we're just gradually seeing, it doesn't look like, it's pretty encouraging that people aren't getting too bored with Snow World. And, that's good to know. And one of the challenges of treating these burn patients was the nurses kept saying, "Hunter, this is working great, but where we need it most is in the scrub tank." So the scrub tanks were, at Harborview at least, is where a lot of the worst, most painful wound care is done early in the recovery process. And so they're sitting in a tub of water. Here's some other pictures. And I designed this special, Jeff Magula built it, a really brilliant instrument maker. I handed him something on a napkin and he made it into this is a optical fiber helmet. Each eye gets 800,000 tiny glass fibers. And so there's no electricity, only photons reach the patient. And it's a little bit, looks a little bit blurry, but it very nice wide field of view, and it's highly effective. You can see we got good results with that too. One of the things that when I had to add this measure, how much time did you spend thinking about your pain? So that's something other researchers haven't studied before. That was something that really struck us, was Well, one of the most dramatic examples was this this rebellious teenager who was being very uncooperative, didn't think VR was going to work and criticizing our measures and being very kind of, so when we asked him how much pain did he feel, he answered the questions with no VR. He answered the questions. And then when we asked him, okay, we put him in virtual reality, and then we asked him the pain ratings, he threw the questions across the table. He goes, how the hell am I supposed to know how much pain I was in? I was in virtual reality. That's a stupid question, You guys don't know what you're talking about. So that was good. We're like, okay, I guess would that be a 0 or? All right. So some people, I mean, you see these late night commercials. We've actually had a few. It's not that common, but occasionally we'll get a patient who says, when are you going to start the therapy? And we're like, we already finished. So that's what we're striving for. That's the ideal. Of course, not everybody shows that. So here's a larger study where we found, and here's another interesting measure that we added that was very controversial. We asked them how much fun, so you ask them a bunch of pain ratings after their wound care, and then you say, okay, how unpleasant was that? What was your worst pain? All right, how fun was that? And they look up at you like, does this look like it's fun? I mean, that is an inappropriate question. So we ended up having to ask that. The nurses kept coming back with that without that answered, and I said, "What? I want to know what the." You go ask them how fun it was. But you ask them the same question after they were in virtual reality, and now they're giving you a moderate fun during wound care. Moderate fun during wound care. And maybe in 5 or 10 years that'll be higher up. Maybe in 20 years kids will be looking forward to their wound care so they can beat their last score or something. It's. I think those are really exciting results. I don't want to get too much into the theory, but I was talking earlier about high presence and low presence, and as predicted, we divided the patient's data just in half. The ones that showed the higher presence ratings, when asked, to what extent did you feel like you went inside the virtual world? It's a very crude measure, but the ones who said higher, showed much better results than the one. So there is a lot of room for improvement, and we've done studies where we've manipulated the quality of the virtual world, and it turns out a lot of these people who are not showing great pain reduction probably would show more pain reduction with a higher quality virtual reality system. So that's encouraging too. It's not like there's some people who just don't respond to it. I think you can get people to respond if you keep working at it. Well, I can show you, actually, if we have time, I can show you some data at the end where we manipulated quality, but one of the manipulations, so I'm talking about factors that immersion, so there's a paper by Slater about factors that contribute to the illusion of immersion, or immersiveness, which is the hardware, the helmet, the quality of the helmet, the speed of the computer, whether your view of the world's occluded, whether you have converging evidence from multiple senses, interactivity. So we've pretty much played around with most of those factors now, and most of them have huge effects on presence and pain. So, and one of the things was we kept saying, if you get a good VR system, we'll give you Snow World. Paul Allen will help. Funding, we can give away Snow World. And they'd say, well, we don't want to pay so much for a helmet. And so then we show them the data. Here's what it looks like with a cheap helmet. If you get a good helmet. So one study, for example, we manipulated the quality of the helmet. We used a gamer's helmet, a side visor. It's about $1,000, very commonly used. And then we compared that to a much more expensive helmet. And with a cheaper helmet, in this laboratory controlled pain study, which is a good lead into where I'm going next, so that's a good question. 1 out of 3 students at the university that were volunteers in this study showed a clinically meaningful reduction in pain with the psi visor, and 2 out of 3 with the high quality helmet. 2 out of 3 showed a clinically, so that's a big difference. In other words, either 1/3 or 2/3 of your patients can respond depending on if you're willing to buy the better helmet. So we don't want to water down the results. We don't want people using Snow World because it takes the hardware. It's a combination of hardware and software and interactivity. All these things come together to create this effective pain control. And I never said it would work with a cheap helmet. Now, it'll work sort of, and you'll have some people who can, you'll show some people who can show dramatic reductions, because there are individuals who are able to have a strong illusion even with a cheap system. So, I think there's a place for a low-end system. The nice thing is that what you mean by low-end, every year it gets higher. Even the low end's I think in a few years it's going to be a moot point. So for example, when we first started doing this, I was using a $175,000 computer. Then that dropped down to $90,000. Now it's down to $3,000. So, people used to complain, oh, I can buy a whole school for $175,000. And it's, a lot of these things just disappear after a few years. Here's a study where we wanted to see what's happening in a person's brain. I mean, it's really interesting to see people, the change from being in pain to being in no pain. And as a cognitive psychologist, I was interested in what's happening in the person's brain when you show virtual reality analgesia, or this big reduction in subjective experience of pain when you're in virtual reality. So once again, we had the technology wasn't available, just like there wasn't a water-friendly helmet. The nice thing about working at the University of Washington, there's a lot of resources, expertise, optical physicists and engineers and we all helping me create this new helmet that can be used in a brain scanner. So now we can study people's brain activity while they're having the illusion of being in a virtual world. And that way we can study virtual reality analgesia. So what we did was we had people look at a cross for 3 minutes, and then they went into virtual reality for the other 3 minutes. And we had pain on, pain off, pain on, pain off every 30 seconds. And I have a couple of papers that describe the design of that study, which is pretty had to be very carefully designed. And I was real happy with our ability to even tease out these data. But that was published in Neuro Report and Central Nervous System. So what we found was big reduction. So here what we found was when the person reports large pain, they're getting a pain stimulus, thermal pain stimulation on their right foot. So we're giving them a hot stimulation, and their brain is showing pain-related brain activity. As soon as the pain goes away, so does the brain activity. And these were in areas of the brain that are well known to be associated with pain. We replicated the literature, and then what we did was we did the same thing, but then we compared that to when they were in virtual reality. Their pain ratings dropped in half, and their pain-related brain activity dropped dramatically. And this, I think, has been very influential results. This is my Scientific American article. And a lot of scientists are really, they're very impressed with objective measures, neural correlates of subjective, instead of just psychological ratings. Sam Shar and I and others have also done, like I mentioned, we did some anesthesiology studies. This is really exciting research where we're starting to compare, contrast, and combine virtual reality with opioid analgesics. So a lot of the patients we had a little bit of a rift, because in the laboratory we were using VR with no opioids, and in the hospital we are always using opioids. It's not possible to take the opioids away. So we always just use VR adjunctively in addition to traditional opioids or whatever meds they're already getting. And that way, hopefully, with the burn patients, the worst scenario is they're no worse off than if they hadn't tried VR. So here in a laboratory controlled study, we had, for the first time, we were able to do a controlled study where we could decide whether or not they got the opioids. All right. So I mean, I won't go into detail here, but what we found was virtual reality worked really well, and virtual reality and opioids combined was much more effective than either one alone. So this is virtual reality. Maybe that's a little complicated, but I think it's exciting. So we're also we've tried virtual reality with a few other pain populations besides besides burn patients. We've used it with patients who had dental fears and showed big reductions in pain and anxiety. I've used it with cerebral palsy patients in Australia during painful physical therapy after cerebral palsy surgery. Here at the University of Washington, we've used it with some older guys during transurethral thermal therapy, and I'm not looking forward to that. And some people are using it with cancer pain. Sam Shar is planning to expand and do some research here at the University of Washington with cancer pain and also side effects during chemotherapy is a possibility. There are a few, as I mentioned, there's a few other places starting to use Snow World. These are really large burn centers. One of them is the Hearst Burn Center in New York, Shriners Children's Burn Center, hundreds and hundreds of kids each year. And soldiers coming back from Iraq after getting in an improvised explosive device explosion often have really bad burns, and we're starting to treat those in San Antonio. Here's one of my earlier studies where we were using virtual reality for treating spider phobics. That's an exciting line of research, and we got really good results, just dramatic reductions in phobia. So that's one of the biggest successes so far using virtual reality for therapy has been with phobias, and now that's one of the now that that's going well, we're trying more ambitious psychological problems like post-traumatic stress disorder. So this yeah, that's a good question. So thank you. So the way this works is the patient has a phobia. They're afraid of spiders. So they avoid spiders. So they might not even come to Microsoft if they thought there was a spider out here. They might miss this talk today because they might think there's a spider in here. So it's So the idea is what they're doing is avoiding the spider. They become obsessed with avoiding the spiders. What we do is we turn that around. What we do is we have them stand across the room from a spider, but instead of leaving, we have them stay there. And they get all sweaty. They might start crying. They have all this fight or flight response. In this case, it's in virtual reality. So they see a virtual spider across the room, but gradually their anxiety diminishes. They habituate. So that a lot of times they're really surprised by that. They're like, I didn't realize that my anxiety would go down if I just stayed here, right? So then we say, okay, what's your anxiety now? It's drop, 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 drop. And we say, okay, you ready to go closer? And they say, well, I don't really want to, but if you tell them, okay, so then they go a little bit closer to the spider. Their anxiety's way high again, and then it gradually goes down. Then they go a little bit closer and a little bit closer. So gradually, and they never get excessively anxious. They gradually work their way up towards the spider, and it's amazing how big of an effect it has because it changes all kinds of things. They're like, I didn't realize how easy this was going to be. You know, if I'd known this, I would have done this a long time ago. And you have to do it in a special way, so you need a therapist there. But the virtual reality is very effective for one thing, the people are much more interested to come in if they know it's only going to be in virtual reality.
In that case, do you have to present something else so that the patient is distracted while the spider is still there?
Well, what happens is once they habituate to the spider, you have to up the ante. In other words, the first patient we treated was nicknamed Miss Muffet. And every week the therapist would say, okay, we'll see you next week, Miss Muffet. We'll have something new for you next week. And I'd be like, okay, I've got a week to come up with something new. I didn't always have everything ready, So one of the things we came up with was this furry toy spider. So once we got to where we thought the end of the study, and he said, y'all see you next week. And I'm like, okay, well, let's try this where they reach out and touch the furry toy spider. So you're always having to up the ante. But I appreciate your asking that because the same technique that we use with the spider phobics is used for post-traumatic stress disorder, which I'll talk about now. It's graded exposure, and it's the same concept, but it's much easier to understand with the spider phobia. it's more intuitively, so that's good to start with that. I appreciate it. So the first study was Barbara Rothman. I'm collaborating with her. She's at Emory. She did this, used virtual reality for, she actually introduced the use of it for phobias, and she also was the first to use it for PTSD. I thought of using it for PTSD, but I was nervous about it's much more challenging. So I was glad to see her do it, and then once she did it, I joined up with Joanne DeFede in Manhattan, who contacted me shortly after September 11th and asked me to help her build a virtual world, help her design a treatment for survivors of the World Trade Center who have developed post-traumatic stress disorder. So just this kind of lines out, just like we were talking about, the gradual progression of increasingly more anxiety-provoking stimuli, but doing it one level at a time so they never actually become excessively anxious. And with the case of post-traumatic stress disorder, it's very similar in some respects. It's related to phobia. They're both anxiety disorders. In the case of post-traumatic stress disorder, the thing that the patient's avoiding is not a situation or an object. It's their own memory for a traumatic experience. They're trying everything they can not to think about September 11th because it's too excessively emotional. They think they can't deal with it. Sometimes they end up having, there's like a 50% comorbidity with substance misuse where, people start drinking because it helps them forget what happened, or they think it does. And basically by avoiding it, they prolong it. So it's the same idea, is by having the patient access their memory for the traumatic event, process the excessive emotions with the help of a therapist, they're able to have a reduction in symptoms and go back to a more normal level of anxiety. Here's one of the more upsetting images. This is an avatar. It's a computer-generated 3D, and this was really upsetting. So once they habituated to some of the earlier ones, maybe after 6 or 8 sessions, we might show them that one, and then after they got over that one, they got a lot better. So these are, it's not only do they show a reduction in, so this was our first patient, and she showed a huge reduction after VR exposure therapy in her PTSD symptoms, and she also showed a big reduction in her depression. So there are a number of other side ripple effects of the treatment, positive ripple effects. That was the first use of virtual reality for treating patients for civilian PTSD. Here's the first controlled study that just came out in 2006 that Joanne DeFede showing big reductions, clinically meaningful reductions in PTSD, and 5 of the 9 patients that were treated with VR in that study had failed to respond to traditional therapy but still responded to virtual reality therapy. That's big because currently there is no plan B for what they call refractory patients who don't respond to traditional therapy.
Excuse me, so what were you showing in the virtual reality for this?
So we showed a simulation of September 11th. So what we showed in the virtual reality to treat the patient is we would show them the Twin Towers, and once they got used to that, we'd show a plane fly over, but it didn't crash. And then we'd show a plane crash, but there was no explosion or sound effects. And then we'd add the explosion, we'd add the sound effects, and then we'd move to the next thing, which was the towers crumbling, the towers with this big screaming and a lot of sound effects. And then we moved to, jumping. The jumping people was a real scare. That was a really upsetting one. And then the full sequence. And what we're doing here is it's not so much that we're basically what we're doing is creating a memory context retrieval. So what we're doing is helping them remember what happened to them. That's what makes this so crucial. It's a crucial point. Is when they go in here, it doesn't have to be a perfect simulation of what happened. It just has to help them remember what happened to them. So as soon as they put on the helmet, like this first patient that we treated, she had been telling the therapist over and over what happened to her on September 11th. But she wasn't crying, she wasn't showing any emotion when she was telling the therapist. She wasn't getting any better. So when we put the first patient in the virtual world, I didn't even get a chance to push a button, and she started crying and just, telling us all about what happened and getting very upset. remembering things that she hadn't talked about before, and all that because basically just being back at the World Trade Center was enough to really just kind of lower her guard and help her gain access to her memory and process the thoughts. And basically what the therapist introduces contradictory information into the memory. So basically you access the memory and you correct misconceptions. Like one thing is the patient was feeling guilty that she was still alive and other people weren't. It's very common, survivor guilt. And the therapist, while the patient is in this state of mind where she's remembering what happened to her, the therapist reassures her, there's nothing you could have done. You're not the one who made this crash. It's not your fault that people died. It's not your fault that you lived. So there's all kinds of input that the therapist can give to help the patient.
So the key is really release of emotions to help the patient to get better.
So exposure therapy, this whole therapy is based on PHOA's emotional processing theory. And the whole idea is that you have to become emotional, you have to gain access to your memory for what happened and process what happened and introduce contradictory information. In other words, the patients have erroneous ideas that are associated with their memory. They have ideas that are contributing to their problem. And so the therapist, not only most of it's exposure therapy. That's my impression, is that a lot of it just has to do from the exposure, but there's also this cognitive restructuring, which involves the therapist is very helpful. Yes, sir.
Do the patients have any control, or are they passive? Do they have like a navigation control?
Well, the way we've been doing it is they don't. In this first virtual world, they simply watch, and the therapist pushes the buttons. Now, they do have some control in that the therapist asks their permission to go to the next level. So they're kind of, basically, the way we kind of present this to the patient is we're creating a context for you to help yourself get better. So the therapist is helping, but really a lot of the work is being done by the patient. And it's, and there's some textbook patterns in their subjective units of discomfort, and as long as they're following these certain patterns. So the therapist, is actively involved. If you tried to do this without a therapist, there's some really good examples of people who saw something on TV. There was one woman who saw something about exposure therapy on TV, and then started treating herself, and she'd go and look over the edge of and then she'd run back, and then she'd come back and look over, and she'd run back. Well, she wasn't getting any better because she wasn't habituating. She didn't, she wasn't doing it exactly. You have to do it just right, but the effects are very strong if you do it right. You can see those are big drops. That's basically you're going from being a PTSD patient to being a non-patient. And there's some new data. Here's another study where we create, Ari Hollander from Imprint Interactive created this bus world, which we designed. I designed with the therapist and Ari and the people in Israel, getting all the pictures and figuring out what the stimuli should be and how to grade it. And so people who witness a terrorist bus bombing in Israel, there are a lot of people who are having psychological side effects from that. So here's the grades here. First you just look at a bus stop and there's no bus. Then the bus pulls up, but it doesn't explode. Then it explodes, but you don't hear the sound effects. So just like it's very systematic. We're pretty much using the same formula for each of these.
It's a gradual.
Exactly. That's right. So now we have one project I'm doing with Sarah Mihira in Hawaii on using virtual reality. We have a lot of patients coming back. So Russ Schilling from Office of Naval Research read my Scientific American article, which I can provide you. Or if you look at my website, I'll show you in a second. You can download it. And he said, have you ever thought about using this technique with soldiers coming back with PTSD? So he helped fund this research, and Paul Allen also, we used some of that money to create Iraq World. And here's a picture of I'm just going to show you that for a second. That's a picture of somebody that was a survivor of a explosion in Iraq, and he has both burns and some of those guys will have PTSD. So here's the website, and we'll be in the cafe this afternoon showing Snow World with immersive head helmet. Does anybody have any questions? Yes, sir.
Very, very impressive. I know nothing about this, but there's been work like a hypnosis being used for pain reduction, and I was wondering how this compares with artificial hypnotic state.
So the question was, how does virtual reality compare to hypnosis? Hypnosis works really extremely well for some people, and we don't really know yet, but my understanding so far is that virtual reality is most effective during painful procedures, during procedural pain, which can last 20 or 30 minutes. So the nice thing about hypnosis is, for the people who respond to it, it might last for days, it might last even longer than days. So you might hypnotize somebody, give them a post-hypnotic suggestion. So depending on what you're using it for, you might choose VR or hypnosis or both. The guy, Dave Patterson, who co-originated the use of virtual reality pain distraction with me, he's a hypnotist. So we're constantly kind of discussing the pros and cons of hypnosis. We have a paper out in 2006 in Journal of Abnormal Psychology where we compare and contrast hypnosis and VR. And the two combined actually work better than hypnosis alone.
You have a lot of people who can't enter this virtual world because they don't play games like this, or they don't...
we have a lot of people who've never played a video game. Thanks for asking that. So Snow World's currently in the Smithsonian Cooper Hewitt National Museum of Design Triennial, and the reason is it has a number of design features. It was specifically designed for burn patients. So most patients, they don't know how to play a lot of patients do know how to play video games, but you don't need to know how to play. Like those older guys in the urology, they'd probably never played a video game in their whole life, and now they had 2 minutes to learn how to play Snow World. Well, as you'll see this afternoon, it's just point and shoot. It's a very simple interface. There's it's very intuitive. So once you get in there, once you hit the button a few times, okay, I get it. It's pretty easy to catch on. And the walls are designed to help guide the person so that they're looking, so they don't move all around and get dizzy, right? So it's carefully designed to minimize simulator sickness. So the audio, Paul Simon came to the HIT lab during his last tour, and he said, "Hey, you need some Paul Simon music in Snow World." So we have Graceland, which just recently was awarded the Gershwin Award. So we have some really great music, and that's I think that dramatically enhances the presence and just kind of gives you a good feeling. That's a positive, upbeat experience.
While the price of the good helmet is high, could you use like a large, projector in a darkened room and get 80% of the effect? What's your feel about how much the helmet actually is?
The people have done that. It doesn't work as well. I mean, other kinds of less immersive. That's a less immersive virtual reality. I mean, there are all kinds of different levels of virtual reality. So we really think the helmet is helpful. Basically, this principle of immersion has been very helpful for guiding, and some people would potentially respond to watching it on a big movie screen. One thing that I made for the Smithsonian, I made this really cool table-mounted display, so you don't have to wear a helmet, but you can still look in these goggles. And I may bring that out to Microsoft sometime. So it has two Apple Cinema 30-inch 2560 by 1600 displays, and those get mirrored into some eyepieces. And so you just look in the eyepieces and you have this really high quality virtual world. So I think you're going to see new kinds of helmets that are not your traditional helmets but are very immersive. I think Bill Gates presented some there are all different kinds of new technologies that are being explored that could potentially be used. And there's new technologies on the horizon. I just read about some flimsy display panels that are like paper sort of, that are going to be coming out in a few years. That's going to dramatically drop the price of the helmet. So I think the price of the helmet's going to go the same way as the price of a computer, that once this kind of makes the transition into mass production. Part of the reason the helmets are so expensive now is, it's very limited. They make them, you call them up and they're like, okay, I'll start making one.
How much are they right now?
They vary dramatically in price.
What are the ones you would recommend?
Well, I have one that I'm just blown away by that works just like incredibly well, and it's $27,500. But if you think of it as a medical device, that's not that much. You think one patient might cost $500,000. A badly burned patient all the way from ICU might cost sometimes $250,000 or $500,000 per patient, depending on what they have to go through. So, that's considering how many times you can reduce pain with it over the next few years. I think it's an excellent investment. Yes, sir. In the back there, I'll get you next.
Single projectors, but there are triple projector flight simulator that can really make you sweat. The illusion is strong enough. Well, so they also cost like $100 an hour.
Yeah. So there are different techniques for creating the illusion. One of the advantages of virtual reality is it's portable. You can bring it. There's all kinds of constraints when you want to use it in a hospital. So I was skiing with a guy in Taos, New Mexico over Christmas, and he was like, what? Do you feel like you're here? What? And I said, well, yeah, but how, you can't do surgery while you're skiing down a mountain. This is very fun and distracting, but the nice thing about VR is you can bring it to the patient and you can block their view of the real world, so any of these other kinds of displays, you're losing big time. That's part of the reason that Nintendo didn't do as well. I mean, if you stuck that in a helmet, it would do better. So one of the, blocking your view of the real world, it has to be attention-grabbing enough that you're willing to give up looking at the real world. Because you can't just put a bucket on somebody's head, they won't let you do it, right? It's got to be something that you have to really have a compelling thing to look at, or they want to watch their wound care. Yes, sir.
Have you compared with the virtual reality for pain control with if you wear a helmet and the patient just play computer game? I mean, they are both with helmet.
Sure. Yeah, so that's a good question. So have we compared VR? Really, a lot of the new virtual worlds are computer games. So the distinction between virtual reality and a computer game, basically if you're wearing a helmet, it's virtual reality. So nice try.
Could different people with different scenarios, maybe for some people, just show them some movie. That might be better than showing it.
Well, that may very well be true, and there are individual variability. One nice thing that we found in the hypnosis study was, hypnosis worked for a subset of the people who had a predisposition to allow themselves to be hypnotized, what we call high hypnotizable patients. So they showed huge reductions in pain, this small subset of the patients, whereas VR worked pretty much for everybody. Almost everybody showed some pain reduction, and most people show large pain reduction. I mean, even opioid analgesics don't work with everybody, right? It shows a normal distribution. So we're already, I think you're going to have a hard time beating virtual reality because it works with even people who don't like it. We had one of the older guys in the urology study was like, I don't want to shoot penguins. He didn't like the world at all. But when I tried to take the helmet, don't take that. Don't. He didn't want me to take it off. He wanted to keep it on, even though he didn't like it. So, okay, I think I have a couple of other. If you want to see it, here's that low-tech, high-tech study where we compared the quality of the virtual world. And so here are some of these systematic controlled studies that we're doing. And we showed this is in this slide, unlike all the other slides, this one's the amount of pain reduced, right? So higher is better in this slide, unlike other slides. So what we found here was a high-tech VR was much more effective. It showed much more analgesia than the low-tech VR. And here's one where we just manipulated helmet display quality, and you can see the low-tech helmet. Everything else was the same in this study. You know, they all had head tracking, they all had sound effects, they all had interactivity. It's just that one of them had a cheap helmet. This was really nice because they didn't know there was another helmet, so they all thought, okay, I'm getting virtual reality, isn't this cool? So the demand characteristics were carefully controlled in this study.
Do you have any concern about the ethics of giving somebody an inferior helmet for your study?
This was a laboratory pain study. So it was healthy undergraduates, you know, suffering for science, volunteers in this study. Oh, so yeah, I mean, I'm not, you know, it's like giving somebody a lower dose. What we've found is we think there's a dose-response relationship for virtual reality similar to the dose-response relationship you get with opioids. With pain meds, you know, usually the more meds you give somebody on average, they're going to show more pain reduction. They probably will also show more side effects. That's one of the reasons they don't give more pain meds is they start having nausea, constipation, all these side effects of the drugs limit how much dose you can give them. Well, what we're seeing here is very simple. This is a high dose of electronic analgesia. This is a lower dose. So it's a dose response. Is it ethical to, if you have a high dose? That's why we're buying the good helmets. I mean, I say give them the best you can, give them the most effective pain reduction you can get your hands on. They deserve it. And there's widespread understanding in the medical community that pain has been undertreated. It's a widespread problem. There are a lot of people who can use better pain control, and there's really, you know, no side effects. So this is like a dream. It's amazing that it's this effective. Okay, let me see if I have any more. Here's a few more brain scans. Okay, next question.
I seem to remember the display expert telling me here some years ago that audio quality actually substitutes in people's brains for display. In other words, if you have very good audio, you think you are seeing higher resolution. Mm-hmm. They've done tests on that. And so you might get, you know, an even greater effect by audio quality rather than resolution.
Well, adding Paul Simon, I think it makes people. I totally agree with that. Basically, you're getting. It's an experience, and it's multisensory, and you know, it's interdisciplinary, and it's a mixture between hardware and software. It's all blurry, and I think that the quality of the music, if you played some really bad music, it's going to make you feel like snow.
This was, you know, not subjective measures of quality, but, you know, literally higher resolution in audio. People say, I am seeing more pixels.
Well, that's subjective. But I mean, if you could, I mean, I would be impressed if I...
You know what I mean?
No, but I would be impressed if you could actually measure higher acuity. Like I can read then that would be an objective measure that would be really, it's like, okay, if you play Paul Simon, I can read the bottom line over there, you know. I doubt that, but yeah. Yes, sir.
Do you have a cognitive theory that explains why this is able to reduce the pain?
Sure. So thank you. There's a really influential theory of pain called the gate control theory of pain. And the idea there is that higher order thought processes from your mammalian brain can send signals down to your spinal cord. There's pathways from your brain. So what you think can send signals down and stop signals from coming in from the pain receptor at the top of your spinal cord. These descending modulatory pathways from your brain can influence how much pain comes in. we weren't able to really isolate that in our brain scan studies because we were only studying upper brain. We weren't studying the spinal cord. And it's also really hard to determine the directionality of activation with fMRI. So we had to kind of back off of making any strong statements about the actual mechanism of how VR was reducing pain. But it's definitely reducing pain-related brain activity. So it's not just a change in the interpretation of the incoming pain signal. It's actual change in the way the brain's processing the pain signals.
So other types of pain that you're dealing with using VR, not being blocked by anesthesia? So you said it's about 20 minutes of procedure, right? Anesthetic.
So the burn patients that we're treating, they have been getting their pain medications, and that's not enough. So like that graph I showed you at the very beginning, where it said during wound care, the majority of the patients report excessive pain. Those patients are getting aggressive opioid use, right? But you can't knock somebody out every day. So there's limits, and there's like I say, the side effects limit how much you can give, and a lot of times it's only for 20 minutes, but I think there's a growing realization that there may actually be long-term consequences of making people endure excessive pain, right? So it may be once you have somebody have a really bad pain experience, most of the nurses will tell you, oh yeah, they'll be more difficult to treat tomorrow because they had a bad day today. That person's you're going to need to up their meds tomorrow because they're anticipating pain, they're more anxious, they're more resistive, they're less cooperative. They're basically expecting to feel more pain, and it's a self-fulfilling prophecy.
So not to use this in the surgery.
Well, I don't know about that. I mean, I can imagine situations. I know there are patients who can't take opioids. There are patients who, they might be hesitant to anesthetize or make them put to sleep, right? If they're allergic to narcotics, for example. So, I mean, what you're seeing, my answer is, the question is, can you use this during surgery? I mean, currently, I think there are some people using it for surgery in Mexico. Hopefully, they're also using other drugs. But the urological study, I think, is a real door that's opening, where the high technology is allowing more and more non-invasive surgical procedures like endoscopic surgeries that don't necessarily require, suddenly you don't have to be put out anymore. You don't have to be knocked out in order to get a knee surgery, as bad as you used to be when they would open it all up. So, and you might even be able to do some of these surgeries not in an operating room, but in a clean, sterile environment, treatment room, which is much less expensive. So I think you're going to see a growing, the irony is the number of people with excessive pain is likely to be growing as medicine progresses, because you're going to be able to do more and more surgeries with the patient awake. So I think sort of you're right. I think you're on the right track that you're going to be seeing. It's a surgical procedure. I mean, the TURP that we did, the transurethral microwave thermotherapy, I think that's a surgical procedure. It's a non-invasive surgical procedure. I wouldn't do open. Yes, sir.
For patients that use this successfully, are they able to, when they're off the VR, recall those experiences and help them control the pain?
That's
biofeedback.
That's an excellent question, and we have had some patients who, and it kind of messes up our experiment when they do that, because the control, suddenly you see their pain during the control condition drop, and
they imagine that they're in snow.
There was one person that I was screening to be in a brain scan study, and I was like, oh, this guy's going to be great. His pain was a 10. He, not 10, but way high. But he could tolerate it, and then I gave him pain with no VR. I gave him pain with VR. Then I gave him VR, and his pain dropped down to 3. And I was like, oh, this guy will be perfect. And then I said, okay, one more without VR, and it was like 4. And I'm like, what happened? You know, so I tried not to act, you know, unhappy, but I said, that's interesting that you showed, you know, you showed a big reduction in pain even though you weren't wearing the helmet. And he goes, oh, I was still in Snow World. You know, he didn't have the helmet on, but I was still thinking about those penguins. So some people I think are, and that's a very interesting possibility. In terms of getting back to your question about the possible long-term benefits, there may be some way to take advantage of VR where you can help people learn that they're able, like, we had one guy, a burn patient, who did the same thing in the scrub tank, where he said, man, I've been meditating all my life. I'm very sophisticated about, I didn't realize I could use that for pain control. Now that I saw my pain drop in VR, you know, now he's like, okay, I know what to do. You know, I just didn't make the connection before. So I think some people, right now it's a pretty limited subset, but it's an interesting possibility. Yes, sir.
It happened in history. Blaise Pascal stopped doing math, went to a monastery, then he got toothache, and during that toothache he did some work on the cycloid, which kept him going.
Oh yeah, to keep from thinking about his pain. and he won the Nobel Prize. Okay.
You're not a mathematician, I believe it.
No. No. Okay. Yes, sir.
There didn't seem to be much connection between the pain work and the post-traumatic work in the mechanism of...
It's, you know, it's fascinating. It's the opposite. That's a very good point. So I had that one patient there, the person who was burned, you know, sitting on the sidewalk. You might not even have been able to see him. I just showed it briefly. It's a nasty picture of somebody somebody literally putting out the fire on his clothes. And he's, you know, that's interestingly, you know, the burns and PTSD are sometimes you get both. You know, the interesting thing about, okay, so with PTSD, we're using virtual reality to help the person approach the thing that they've been avoiding, right? Approach their own memory. They've been avoiding it. We use virtual reality to force them, not force them, but to help them to approach either the spider or whatever it is that they've been avoiding. We use virtual reality to help them learn how to be more comfortable approaching it. All right? Well, with Snow World, we do the opposite. We're giving you an escape route. We're helping you avoid your pain. You want to get out of the hospital. You know, escape is evolutionary functions of pain. So usually when you feel pain, you leave the place, you leave the situation that's causing the pain, and you're more likely to live, to reproduce if you do that, right? So people who can't feel pain, you know, sometimes they die from the most surprising ways because they just didn't realize that they were being injured because they didn't feel the pain. So escape, that's part of the reason I think Snow World works so well, is it taps into this really ancient tendency to want to get out of a place where when you're in pain, the person wants to get out of there, you know. So they want to leave the room. So if you give them Snow World, even if the world's not very good, they'll say, okay, I'll buy it. You know, if it'll get me out of here, I'll go into Snow World. You know what I mean? It's like that older guy's like, I hate penguins, but if it makes me feel less pain, I'll do whatever you tell me. So one of them helps it's interesting that one virtual world works by distraction, by luring your attention away from your problem, and that's why we need the high technology. That's a very interesting point when it comes to practicality. I don't think you need as high-tech equipment for treating PTSD, because what happens there is the problem enhances the experience in the virtual world. You're filling in a lot of the information from your own memory. Your physiological arousal is enhancing your experience, so you're like, you know, really getting a good experience out of this spider world, even though the spider may be ridiculous. You know, the first spider I made was like a ball with sticks coming out of it. I was a laughingstock of the hit lab, but it scared Miss Muffet out of her wits when she saw it. But with the opposite's true with Snow World. In Snow World, I'm competing against the problem. The technology is competing with the problem. Instead of the problem helping the illusion of presence, the pain is distracting the patient away from snow world. So they feel more present in snow world. I mean, you can understand that. You're not going to really get into playing a video game if somebody's stripping skin off your arm, right? So I really have to do double good. We really have to work. We've been putting a lot of effort into snow world so that it can be effective and it is kind of like, you know, either or. I mean, that's part of the reason I'm so driven to make snow world better and get good equipment, is I've seen these really frustrating cases where it was working and the nurses were so happy because this patient's been having a hard time and it's working and everyone's very impressed and he's shooting snowballs, and then you can see something happen and it's almost like a spirit coming out of snow world. You can tell he stopped shooting snowballs. He says, take this thing off of me. You know, it's not working anymore. What happened is the pain won. And, you know, and if I had Snow World better, I bet you I could have kept him in there. So I'm constantly haunted by, you know, the ones that don't respond well. Yes, ma'am.
I hope you didn't address this before I got here, but do you think that it would make a difference to have more ambient sounds that coincide with the, you know, what they're seeing versus just having music playing?
Well, yes. The converging evidence from multiple senses helps the person believe what they're seeing. So we do have sound effects when you shoot a snowball, and we'll have this available in the cafe this afternoon, starting Donna, what time? 1:30 or 2? So 1:30 or 2, you'll be able to try it for yourself. And what happens is, when you shoot the river, you hear a splash. When you shoot the igloo, it shatters, and you can hear a shattering noise. You know, if a snowball's coming in, you can hit it with you can knock it out of the air. So the new version of Snow World that Imprint made, the snowmen are throwing snowballs back at you instead of just standing there. You know, so there is a lot of we do use the sounds, and the sounds are incredibly important with treating PTSD. I mean, it's amazing how, you know, the sound. If you can get the sound right of a bullet whizzing by, somebody who's been over in Iraq, that really works, you know. And having the context, at least a primitive context of moving in a convoy, to give that sound a meaning, I think you need both. I think the sound alone is not as effective, but yeah, the sound's critical. And actually, Ari Hollander's a sound man. And so is Russ Schillings. So there's a lot of sound experts involved in our research. Yes, sir.
When my pediatrician as a child gave me a lollipop to get my inoculations, this was to distract by sensory means, or this was...
I think they were bribing you.
I think so. But maybe a popsicle will help in your...
Well, I had a chocolate world where you could physically eat a virtual chocolate bar. It was very popular, except I was going broke because every time I gave a demo it cost 50 cents. So I had to quit giving that one. But you'd take a bite out, you were in Kitchen World, you had a hand-tracked chocolate bar, and I'd say, okay, take a bite out of it. They'd put it under their helmet, physically take a bite out of it, and I would push a button, you know, to change the graphics so it had a bite mark, and they would just be like, wow, how did you do that? You know, that was very confusing when they saw the bite mark. And they're sitting there chewing, you know, what am I chewing? Is it real chocolate? Is it virtual chocolate? So that's a lot of fun. We did that with some of the patients too. We even used that with some of the patients, Chocolate World. I think that's another another sense, adding more senses. And some of the new PTSD worlds are adding smells. I'm not messing with that yet, but Barbara Rothbaum's using a smell machine, so you know, when you see an explosion, you might smell some gunpowder. That could help a lot, I think. If you did it well, I think it's tough to do it well. If you don't do it well, it'll detract. Yes, ma'am.
So you've mentioned a number of different worlds that you've created. Are there any other disorders that you've specifically tried to help with your different virtual realities?
Well, I have focused on, I've decided to go deep with a few. Dr. Patterson actually was the one who encouraged us to stay with burn patients as our primary patient population. and that's worked out real well. So we've learned a lot, and that I think will generalize real well to other patients. Now with the phobias, there's a lot of temptation. You meet people all the time who have some kind of interesting phobia that you'd like to treat. One thing that I did recently with Azucena Garcia Palacio, one of my colleagues, we put the patient into Snow World to distract them from claustrophobia. So it's kind of a trick. So it's a mismatch in a way. So earlier I was saying we're using virtual reality to have you face your fear. Here we were using virtual reality with a phobia to distract the person from their fear. It worked really well. So we had patients who we selected patients who were unable to tolerate a mock brain scan. So they said, "Get me out of here." So it was supposed to be a 10-minute scan, and both of them came out before 6 minutes. They said, high anxiety. The anxiety was 9 out of 10. Okay, one of them gave just music only. She said, "Get me out of there," after only 3 minutes. It didn't even, if anything, it didn't help at all. And then we had one woman who was just randomly assigned, and she went into Snow World before we put her back in there. And she went all 10 minutes, and we said, "Are you ready to come out?" And she goes, "I can stay in here either way." Her anxiety was only a 3. So maybe just to help somebody tolerate. So that's an interesting idea, using virtual reality to distract patients, because there's a surprisingly large proportion of people that don't even know they're claustrophobic who have trouble tolerating a brain scan. Between 3 and 20% of brain scans are lost, either because a person decides they don't want to show up, or they don't want to stay in there the full time, or it can delay how long it takes because you have to medicate them or whatever, so that could be real helpful. And that's one of the perks of building these goggles, is that you're like, okay, what else can we use them for now that we've got, now that we've got goggles in the scanner. Yeah. Okay, well, thanks a million for coming. It's very interesting.